All right. So thank you all for joining us today. As I said, I'm Michaela. I am the Program Director Prevention Policy for the Hepatitis B Foundation. And today we are hosting a webinar focused on the hepatitis B birth dose, what it looks like in Pennsylvania moving forward, and how we can speak in a culturally competent way to mothers who are living with hepatitis B about the importance of this birth dose for their families and for their children. And so this webinar will be recorded and we will have slides available after the end. So if you need to hop off at any point in time, no worries. We will send this out to everybody. While we are in the webinar, everybody will be on mute, but there is a chat. So feel free to drop any questions or comments in the chat. We will get to those at the end. And now we will go ahead and move forward. So as I mentioned, this webinar is in partnership with the Pennsylvania Department of Health, which we're very excited about. And we have some really great presentations for you all today about hepatitis B in Pennsylvania, looking kind of at the epidemiology of what's going on, the birth dose, and what it's like moving forward. And so I think we are all pretty familiar with the Department of Health. So I just wanted to do a quick introduction to the Hepatitis B Foundation since I see a lot of new names in the line. But the Hepatitis B Foundation is located in Doylestown, Pennsylvania. We're a national nonprofit that really works to address hepatitis B, hepatitis D, and liver cancer globally, as well as in the United States. And we do this through outreach and education, public health research, policy and advocacy, and education and training. But we also have a research branch with our sister organization that works on identifying a cure to hepatitis B and other liver diseases as well. And before we get started, I just wanted to do a quick shout out for our webinar that is coming up, since I assume some of you might be interested in it. But we are hosting a webinar focused on the new AASLD 2025 Hepatitis B guidelines and updates that will be on Thursday, February 26th. We will be able to share a registration link in the chat and after the webinar as well. But in case you're interested, just put that on your calendars. And I will get us started with a quick overview of some of the ACIP changes and where we kind of go from here on a national level before we dive into the state level. But as a quick overview, I assume a lot of you probably are very familiar and have heard and been attuned to what has been going on. We did have some changes, not only in the overall childhood immunization space, but specifically with hepatitis B beginning last year. So in October 2025, the ACIP, the Advisory Committee on Immunization Practices, established a childhood and adolescent immunization schedule work group that did a deep dive into hepatitis B, specifically the birth dose. We saw that kind of come to fruition in December 2025 when they voted to remove the federal recommendation for universal hepatitis B birth dose and recommended that if the vaccine is not given at birth, and it will be given, it should be given at 2 months, no earlier than 2 months. And there's no more catch-up period recommended as well. And that little piece was kind of put into practice in January 2026 when we saw the ACIP alter the entire childhood immunization schedule, which reduced routine immunizations from 17 that we previously had in the United States down to 11. And childhood hepatitis B vaccine was one of those, kind of shifting from routine to high risk. And I'll get into that a little bit more in just a second and what that means in kind of plain terms. So the first recommendation that I wanted to do a deep dive in at the top is the actual federal recommendation from ACIP in the language that they use, and on the bottom is the translation in just very simple terms. But essentially, what we're seeing right now is that the federal government is recommending that only babies born to mothers living with hepatitis B and of unknown status should receive the hepatitis B birth dose, which is a switch back to the risk-based recommendations that we previously had in the 1980s. And we also see with this recommendation that babies born to mothers who don't have hepatitis B and are not of unknown status should begin the vaccine series at 2 months of age, and that decision should be made in consultation with the provider. So we don't have a universal hepatitis B birth dose recommendation on the federal level any longer. The childhood part is a little bit more complicated for The hepatitis B space, we did have a universal childhood recommendation on the federal level that was essentially what we call a catch-up period, because typically the birth dose started at birth, and then we had a 1 month and then 6 month series, or I should say doses. So a 3 dose series that would be completed at 6 months, and then if they didn't complete that, there was a catch-up period. But now the federal recommendation is that the catch-up period should essentially be only for children with risk factors, if they did not complete the full, if they're going to complete the full vaccine series. Now, as I mentioned, those are the new federal recommendations, but we have seen a lot of states, including Pennsylvania, kind of stand up and take a lead in making sure that we still maintain access to the birth dose for all of those who want it, and that we still have very strong evidence-based recommendations, which I will allow the health department to chat about in just a little bit. But I just wanted to highlight that we are one of a number of states who are making sure that we still have increased access to the birth dose, especially the universal birth dose recommendation on the state levels. And so, some other things I wanted to very quickly highlight is that there's been no new evidence to support that the universal birth dose is not effective and is not necessary in the United States. In fact, we see the 12 professional medical societies, including AAP, ACOG, AMA, and numerous other institutions supporting the universal birth dose and this continued um, space after the federal changes. And they also continue to support that 3 doses of the hepatitis B vaccine is necessary to achieve full immunity. There's been no evidence to support that fewer than 3 doses can achieve lifelong immunity, which is why it's really important that we're making sure we talk not only about the birth dose, but those 2 subsequent doses that children should receive as well. And one other thing that I think comes up quite often and is very important to highlight is that even though the changes did happen on the federal level, all forms of insurance do still cover the hepatitis B birth dose, so commercial, CHIP, vaccines for children, and Medicaid at this point in time. And so for plans underneath the Affordable Care Act, there is still no deductible and no copay, so nothing has changed there. And the CDC does also say within their federal changes that shared clinical decision making can be made in consultation with any nurse, pharmacist, or provider. So that has not changed. And ultimately, at the end of the day, the message that we want to stress is that this is still an accessible vaccine. You can still offer the birth dose, it will still be covered in all other doses of the vaccine as well. And before I turn it over to the health department, I have one more quick thing that I just wanted to add. Um, but one of the things that I think a lot of providers and a lot of us here in the line are currently struggling with is how to talk about these changes in the federal space. We have differing federal guidance. And I think what's really important for us their messaging across the board. So one, the birth dose in HBsAg, especially if the mother is living with hepatitis B are still essential to preventing transmission. It's full series completion that achieves lifelong immunity, which is why we do 3 doses, and you can still access the vaccine with no cost sharing. For all of us here on the line, I think it's very important that we are prepared to questions from parents. We're seeing a lot more questions that we might not have seen before in this space because hepatitis B has been such a routine vaccination. And now that it's kind of being called into question, we are seeing a lot more concerns. And concerns are great because it shows that they care, but we just have to be prepared to address them. So questions around the safety of the vaccine might come up or why the vaccine is given at birth. And there might be specific questions around high risk groups, which is something that we're also going to talk about today. And finally, one thing that we can do to assure that parents feel comfortable in the decision that they're making is to affirm evidence-based science and issue very clear guidance moving forward. So that is pointing to the state and local health departments and the guidance that they have, and pointing to the medical and health professional societies like the ones I pointed out on the other slide that are still continuing to recommend the universal birth dose because it still has evidence to support that. And with that, I'm happy to turn it over to my colleagues at the State Health Department to get into their presentation.
Thank you, Michaela. Can you hear me?
Yes, we can hear you.
Wonderful. Thank you. So my name is Sherry Minier. I am the perinatal HepB consultant for Pennsylvania Department of Health. I cover the entire state minus Philadelphia, and I'm going to let Lauren introduce herself.
I am Lauren Orcus. I lead viral hepatitis surveillance and prevention work at the PA Department of Health. Happy to be here.
Thank you, Lauren. I also just wanted to take a second to introduce my other colleague, Madeline Blouse, who's also on here as well. She's not listed on this presentation, but she does help me with a lot of behind the scenes things in the perinatal Hep B program. So one of the first things I wanted to start off with and talk about why is hepatitis B important. The two main things we're going to be talking about today on my presentation is all things perinatal Hep B, and we're going to be diving into a little bit of refusals and what to do if we have a refusal from a parent that has hepatitis B and it has a newborn. So why is hepatitis B so important? It is a vaccine preventable. It's highly infectious, even in the absence of visible blood. It does live on the surface for at least 7 days. Chronic infection can occur up to 90% of infants who are infected at the time of birth and early childhood versus that 1 to 12% of the individuals over the age of 6 at the time of infection. Another key aspect is there's no specific treatment for acute hepatitis B. Next slide. Some key statistics, and again, what makes perinatal Hep B such a big deal. 1 in 4, or about 25% of people who become infected during childhood will die from cirrhosis or liver cancer versus the 15% that contracted after childhood. Most babies are asymptomatic. Babies born to a hepatitis B surface antigen positive mother in the absence of post-exposure prophylaxis, so hepatitis B immune globulin, HBsAg, and the hepatitis B vaccine series, up to 90% will become chronically infected. However, on the flip side, if we give prophylactic treatment, HBsAg and hepatitis B immune globulin, or hepatitis B vaccine, we have up to a 95% effect in preventing chronic hepatitis B. So we have the treatment. Next slide. Some key numbers from history. In 1990 to 2004, we had an acute hepatitis B reduced by about 75%. Our greatest decline was in children and adolescents. We saw a huge 94% decrease. However, even with all of our improvements that started in 1990, CDC's national rates show that we're still only finding about 50% of expected births to hepatitis B moms. I will say in the state of Pennsylvania, in our jurisdiction and Philadelphia jurisdiction, we do an amazing job of finding our cases, and I believe our number is much higher than this. Next slide. I'm going to turn this part over to Lauren to go over some of our state numbers.
Thanks, Sherry. So I'm just going to discuss some surveillance data we have available in Pennsylvania through 2024. And the data you see here do exclude Philadelphia because Philly does an amazing job on their surveillance and themselves. But if we did include Philadelphia data, our rates would still be lower than those national rates. So again, for PA excluding Philly, our rate of acute hepatitis B decreased prior to 2020 and increased post-pandemic, likely reflecting a return to healthcare seeking behaviors. However, the number of our acute hepatitis B cases in 2024 was only 49, very, very likely reflecting an underestimation. Acute hepatitis B, for many reasons, is hard to count with our surveillance data. The rate in Pennsylvania, though, is lower than the national rate, as I mentioned. And nationally, we did see an increase in acute hepatitis B post-pandemic as well. Next slide. So this map here shows a gradient scale of acute hepatitis B rates by county, and we see higher rates in the Northwest, Central, and Northeast parts of our state, but we also see rates that are a bit higher in other rural areas of the state. In 2024, Mercer County had the highest rate of acute hepatitis B at 4.6 per 100,000 population. Next slide. So unfortunately, there's no national comparison available that's reliable across the nation for chronic hepatitis B because not all states report chronic hepatitis B cases to CDC. So here we're just showing the PA rate. And again, excluding Philadelphia, we see that our rate of chronic hepatitis B increased since 2020. And in 2024, there were 1,945 new chronic hepatitis B confirmed and probable cases reported to the state health department. Next slide. So again, here's a gradient scale, but this is showing chronic hepatitis B rates by county. And we see higher rates in the southeast and south central parts of the state. In 2024, Delaware County had the highest rate of newly reported chronic hepatitis B cases with a rate of 44.5 per 100,000 population. Next slide. And this map looks a little similar to the last, but these are perinatal hepatitis B exposures occurring really across the state with many infants born to moms living with hepatitis B. However, as we've discussed and are going to discuss, we have very effective interventions to prevent perinatal hepatitis B infection at birth. In 2024, the highest rates of perinatal hepatitis B exposure particularly occurred in the southeast. Again, Delaware County having the highest rate of perinatal hepatitis B exposures at 636.5 per 100,000 births. Next slide. But really is a testament to all the work that you all do that are on the call, as well as Sherry and the perinatal hepatitis B prevention program at the state. We have not identified a confirmed perinatal hepatitis B case since 2019. The one KCC reported in 2021 is a probable case, so we're a little less confident there. So we say 2019 was the last we'd seen a confirmed case. However, with the change in the ACIP HepB birth dose recommendations, we unfortunately do expect to see vaccine hesitancy amongst mothers living with hepatitis B and may see more perinatal hepatitis B transmission, unfortunately. And I do see the question in the chat, why are we excluding Philly? So in our role at the state, we receive funding to conduct surveillance outside of Philadelphia. So we work very closely with our health department colleagues at the Philadelphia Department of Public Health, but these data are excluding Philly for those reasons. And I'll put a link in the chat to the Philly data. Next slide. I'll turn it back to you, Sherry. Thanks.
Thanks so much. I just want to start again with just a little bit of more history. So in 1991 is when the United States adopted a strategy for universal hepatitis B vaccine. And I want to stress, even though we have had the federal change at the ACIP level, withdrawing that universal hepatitis B, we still are doing the universal hepatitis B of our infants in the state of Pennsylvania, in Pennsylvania jurisdiction, and also Philadelphia jurisdiction as well. Also in 1991 is when we introduced hepatitis B surface antigen testing of all pregnant women, and then prophylaxis for all of our infants born to these hepatitis B positive mothers. The universal vaccination started back in 1991, and we also added routine vaccination of our previously unvaccinated children and adolescents, and then vaccination of adults at high risk for Hep B. Next slide. I want to change gears a little bit and talk about Pennsylvania Department of Health requirements, guidelines for the medical care providers. And you can access this link at any time. It's always on our Pennsylvania Department of Health. That is always the most up-to-date copy, and you can access it on our website. So PA Code 27.99A states all pregnant women are to be screened for hepatitis B surface antigen on the first prenatal within 15 days, but no later than time of delivery. That last little section is super important for any mother that did not get prenatal care. So every time a mother presents themselves to a birthing hospital for delivery, we would want to establish their hepatitis B status. It's also important to draw a hepatitis B surface antigen on every pregnancy, even if you know that they have a chronic history. That positive lab is what comes to us at the Pennsylvania Department of Health, also Philadelphia Health Department, and alerts us to their pregnancy. If the practitioner gets a positive result, You will report this through our ELR system, electronic laboratory reporting. It is reported through PA-NEDS. It is most labs have this set up automatically. Some still do a hand entry, but most of them do it automatically, and it's just done without any thought. At this point, you want to recall the patient to the clinic and let them know of their status, provide education, and perform a medical evaluation. Next slide. A key aspect of perinatal Hep B is doing a hepatitis B DNA lab. So the CDC current recommendation is to do it in the first trimester or whenever you figure out that they're pregnant and they have hepatitis B. So that could be the second trimester as well. And again, at 26 to 28 weeks. That second DNA is super, super important. The 26 to 28 week viral load will guide the use of maternal antiviral therapy during the pregnancy. If they have greater than a 200,000 IU per ml viral load, what we normally do with HBsAg and hepatitis B vaccine series is not usually enough to prevent transmission. So if the mother has a greater than 200,000 at that 26 to 28 week gestation, that's when we would want to do antiviral therapy. So the DNA test, I can't stress how important it is to make sure you're getting it preferably twice at some point in the beginning part, and then again later at 26 to 28 weeks. At this point, you would notify the hospital of the mother with the upcoming due dates. Usually, most providers work in the same hospital system, so again, that's usually a seamless process. We also, at the PA Department of Health, notify the birthing hospital of upcoming due dates that are within about a month or two, but obviously we wouldn't know about any that did not have any prenatal care. Next slide. Once the woman presents to the hospital for delivery, every birthing hospital should have some sort of policy in place to check their hepatitis B status. So preferably you're looking for a hepatitis B surface antigen. There can be some other various hepatitis B labs in there as well. If you cannot find that hepatitis B surface antigen test, or they did not have prenatal care, it's unavailable, the hepatitis B surface antigen testing should be performed immediately. Within 12-hour birth, all newborns born to a hepatitis B surface antigen positive mother or an unknown status, and we'll talk more about that unknown status in a little bit, should receive a single antigen hepatitis B vaccine in HBsAg in different limbs. If the mother is hepatitis B surface antigen negative, a full-term medically stable infant greater than 2,000 grams should still receive the hepatitis B vaccine within 24 hours. Again, we are still keeping the universal hepatitis B birth dose in the state of Pennsylvania, Pennsylvania jurisdiction, and also Philadelphia jurisdiction. If you have a preterm infant laying in less than 2,000 grams born to a Hep B negative mother, they should receive a single antigen hepatitis B vaccine 1 month after birth or at hospital discharge. Next slide. Guidelines for the medical care providers. If you have a mother that's coming in for delivery that is high risk, so you want to repeat hepatitis B surface antigen at the time of admission to our hospital if the patient is at high risk for any of the categories. Recent or current injection drug user, more than one sex partner in the previous 6 months, hepatitis B positive sex partner, evaluation of STD, or symptoms of clinical hepatitis. I do know there are some birthing hospitals across the state that do it for every mother, and that is perfectly fine. Every mother that comes in for delivery, it is really up to the birthing hospital. The only key aspect I wanted you to keep in mind there is please do not ignore their previous testing during that pregnancy. So if you get a negative now, you still need to look at that previous testing. Next slide. Any infant born to a hepatitis B positive mother with a birth weight of greater than 2,000 grams administer hepatitis B vaccine and HBsAg within 12 hours at different sites. The second dose is due 1 to 2 months of age with a minimum of 4 weeks from the first dose. The third dose no earlier than 24 weeks with an interval of 8 weeks from the second dose. And then serology will be done at 9 months of age, and we'll talk about that in just a minute. Next slide. If you have an infant born to a hepatitis B positive mother and the birth weight is less than 2,000 grams, again, you're going to administer a hepatitis B vaccine and the HBsAg at different sites within 12 hours. This first dose of the hepatitis B vaccine does not count because of the reduced weight. 3 additional doses for a total of 4 doses should be administered. Second dose would be given 1 to 2 months of age with a minimum of 4 weeks. Third dose, 1 to 2 months after the second. And then the fourth and last dose is again given at 6 months of age with at least an interval of 8 weeks between the third and fourth. And then again, serology at 9 months of age. Next slide. So serology does consist at 9 months of age in the state of Pennsylvania with at least 1 month after the last hepatitis B vaccine. This will consist of the hepatitis B surface antigen, where we are looking for active disease, and the hepatitis B surface antibody. And we want this to be greater than 10, and we're looking for a quantitative test here. Testing will likely occur at the pediatricians. They usually will be giving them a lab slip. Most pediatricians don't do them in-house anymore. If the infant is still in the hospital, and this is a true rarity at 9 months of age, then the hospital would be completing this section. Next slide. This is a really key aspect of why we manage these cases so well in the state of Pennsylvania. We do an amazing job of preventing perinatal Hep B transmission. We have a big working relationship with the birthing hospitals. We notify you, and then in return, you notify us when the mothers come in for delivery. So it's a very important piece of why we do so well in Pennsylvania, especially if the mother has no prenatal care. The Department of Health, we at the Department of Health and also the Philadelphia Department of Health may follow these children up to 2 years of age. We usually are able to close these cases and get serology by 1-year-old, but we may follow them up to 2 years of age. It's also important to just remind you, if the baby contracts hepatitis B at birth, up to 90% will develop chronic infection, and 1 in 4, those are really big numbers, of those people will die prematurely. Next slide. This is, again, just a PA code 2827.21AA. It's just a regulations that mandate reporting to us within 5 days of when they present to the hospital. Next slide. Again, it's spelled out here just at the bottom, hepatitis B, viral, acute, and chronic cases, still under the same regulation. Next slide. Now, you do have 2 options when you report these deliveries to us. Now, in Pennsylvania jurisdiction, you have the option of using the case report, which I'll show you on the next slide, or by putting the baby in PA NEDS as a baby born to hepatitis B surface antigen. One note here, though, Philadelphia Department of Health only uses the case report on the next slide. Next slide. So this is the case report that you can use. We use the same one for us and Philadelphia. You can access this report at this link. I always recommend using the link. It's always the most up to date. I'm doing a couple little tweaks on here, and we'll have a new updated one on the website, but you can access them at this link. You would just fill this out, and then the instructions are on the bottom. There's instructions for if the mother lives outside of Philadelphia, and then also instructions if the mother lives inside Philadelphia. Next slide. This is the biggest piece of information I wanted to discuss today. We are starting to see hepatitis B infected mothers give us refusals. Prior to this year, this was extremely rare. And when we had the rare occurrence, we were usually able to give education and explain the significance of not given treatment. However, with the current ACIP discussion around the birth dose of hepatitis B, we at the Department of Health and the Philadelphia Department of Public Health are starting to see confirmed hepatitis B mothers refuse infant prophylactic treatment of the hepatitis B vaccine series, the HBsAg, and the serology. The key note here is to know that this may result in dire outcomes to the infant later in life, to include early death. There is a nice link here from CDC. It just basically states approximately up to 90% of infants born to hepatitis B surface antigen positive people in the US will acquire chronic, and then 1/4 will eventually die from chronic liver disease. Next slide. So these are the next steps. These are the things that we recommend that will be the best next steps for you at the birthing hospitals. It's important that every birthing hospital and children's hospital has a policy in place to anticipate refusals. Prior to this year, it was not such a big deal, but we highly recommend that you have something in place to anticipate it now. You would want to educate the parents and the mother to include the CDC statistics on the previous page, to include that infant prophylactic treatment of the Hep B vaccine series and HBsAg and serology can be life-saving. It is not just a vaccine. There is no cure for hepatitis B. It is highly contagious and spread through pregnancy, childbirth, blood, bodily fluids, sharing personal items. This is the thing a lot of people don't realize. Sharing personal items such as fingernail clippers, toothbrushes, razors, and then of course everybody knows the sexual contact and the sharing needles. The majority of our hepatitis B infected pregnant women have lifelong, they contracted it at birth, it's chronic. The majority, almost 90%, are foreign-born. They're asymptomatic and do not understand the infection. Most of them have no idea they have hepatitis B until they come here and we test them. And they have gone their whole life with having any issues, and they think that it's not such a big deal now. So the education is extremely important. While they are highly contagious, especially to the household members, hepatitis B infection usually will not affect them till later in life when they're done having children. Next slide. We also recommend that you consult your legal team for guidance if the mother or parent still refuse infant prophylactic treatment after education. Ideally, again, a policy should be in place prior to any refusals. If the hepatitis B mother or parent refuses the infant treatment, please notify myself at the time of the delivery before discharge or Jennifer in Philadelphia jurisdiction. And then here are all of our contacts. We also ask you to fill out the case and contact report and just let us know right away that you're having this refusal. I will say that we were seeing a national trend when the ACIP was in the news a lot with taking away the birth dose. We were seeing a handful of cases across the nation and in the state of Pennsylvania. Knock on wood, since the news has not really been talking about it, we haven't had a refusal for a couple months now, but we anticipate that there will still be continuing to have some refusals. Next slide. This was a key change that I wanted to bring to everybody's attention. So with the ACIP removing the federal birth dose recommendation, CDC updated the current guidance. So it used to be different weights had different outcomes, but now all infants, so regardless of the weight, born to any woman of an unknown hepatitis B surface antigen status, should receive a hepatitis B vaccine and HBsAg within 12 hours of birth. So the key change is all infants, and it does not determine upon their birth weight. Next slide. Here are some key links that we have listed for everybody. So the ACIP meeting from December 5th, the fact sheets on that. We have general immunization guidance on our Pennsylvania Department of Health website. Governor Shapiro's September 22nd press release. We also have a nice link for our current vaccine recommendations. Again, in the state of Pennsylvania, we have not changed any of our vaccine recommendations, and we are following the American Academy of Pediatrics, the American Academy of Family Physicians, and the American College of Obstetricians and Gynecologists. Next slide. We did establish something called PA Cares a little while back. It's under Executive Order 2025-02. It established a vaccine advisory work group, specifically called the Northeast Public Health Collaborative. It is called PA Cares and was set up to ensure continued coverage for all vaccines that are currently covered under the VFC. Currently, right now, everything is still covered under all insurances in the VFC program. Nothing has changed. But PA Cares is here just in case something would change in the future to make sure everybody still has access to all vaccines. Next slide. At the PA Department of Health, we do have a little handy brochure that you can access at this link. You can print it out in English or Spanish. It is very simple and easy to follow. The one side is meant for the parents. We do have the statistics there. And on the other side is meant for the providers. We have a schedule of the vaccines themselves and then the serology that is due at 9 months of age. Next slide. We have some additional guidelines here. We have a link for the perinatal HepB program. You can access all of the documents that we discussed from that link. There's also a very nice article from the Hepatitis B Foundation that talks about the universal Hep B vaccine birth dose and how it has saved thousands of lives. Next slide. And that concludes our presentation. I'll turn it back over to Michaela.
Thank you so much, Sherry and Lauren. I'm going to go ahead and pull up a presentation from our other colleague who's actually based in Philadelphia. She will be presenting on the work that she does in the community and what she's been hearing from community organizations on the ground, and community members on the ground, I should say, around their concerns around the hepatitis B vaccine and the birth dose specifically in African immigrant communities. And just pulling her slides up right now. I believe you should be able to see them, but Afisa, please feel free to hop on.
Thank you, Michaela. Can you hear me?
Yes, we can.
Wonderful. So, yeah, I would like to speak a little bit about the culturally competent hepatitis B vaccine messaging in the African and Caribbean community in Philadelphia, or the greater Philadelphia. Next slide, please. So I would like to start off with a couple of data, just to give some context, right? So there was a study, a community-based screening study that was conducted back then in 2020 among our African-born immigrant community in the greater Philadelphia that showed that the hepatitis B vaccine, the hepatitis B infection among this group was 7.9%. So this is a high rate, right, compared to the rate of hepatitis B infection prevalence in the Philadelphia general population. Next slide. So given this context, so we know that the African and Caribbean immigrant population in the greater Philadelphia is at high risk of hepatitis B. That's one thing. The second thing also is that it shows clearly there is a need of hepatitis B vaccine in our community. So in order to cover this issue, we think there are at least 3 questions that we need to ask ourselves that need to be discussed. First, what are the current barriers to vaccinating at-risk communities in Philadelphia? And what are the parents' core concerns about vaccinating their babies and children against hepatitis B in the greater Philadelphia? And again, this is speaking to African and Caribbean communities residing in Philadelphia. And how can doctors speak with African immigrant communities about hepatitis B infection and hepatitis B vaccine in Philadelphia? Next slide. So before we cover these questions, I would like to give a quick overview of our organization, AFAO. AFAO was founded in 2005, and it was mainly focused on testing and HIV testing and prevention among African and Caribbean communities living in Philadelphia. So over the past few decades, especially 2 decades, I think, AFAO has expanded its services to health, social, and educational areas. Next slide. So our social programs include connecting families to legal services, social benefit application. We do provide case management and support to survivors of domestic violence, sexual assault, and female genital mutilation. Through our emotional wellness program, we provide mental health support groups and individual counseling. We provide food to family in need through our food assistance program. And we kind of support and prevent our elders from social isolation in the community for our Elders Wisdom Circle. Next slide. So our educational programs include adult learners program, especially the English as second language, but also digital literacy. We offer youth program as well. That is for our IEP program. It's basically focused on after-school program, summer camp to youth who are at the middle school or high school. We offer as well post-secondary education assistance and mentoring. Next slide. So our health programs include linkage to medical care, family planning, and vaccine for our partnership with the CD Health Centers for FQHs and also our evening clinics. We have sexual and reproductive health program, and this embed family planning and maternal child health program. And through this program, we provide educational health workshop and screenings. We have as well chronic health conditions and emerging issues program. And under this, we provide as well educational workshop and screenings. And specifically, I want to point out our health awareness program that has been a new program we started a year ago. And this program is mostly focused on those who are impacted with chronic health conditions unmanaged. We provide a client-oriented and one-on-one case management to help them manage their conditions. So under the health program, we have as well mental health program, and we offer therapeutic sessions and screenings. Next slide. Next slide, please. All right, so in 2024, FAO opened a clinic located in Derby. And at the clinic, we provide services to uninsured or low-income African and Caribbean living in the greater Philadelphia. So we offer basic primary care services, chronic health conditions management, and recently we added to our services gynecological services and psychiatrical services. Our clinical team is made up of one medical doctor and two nurse practitioners. Next slide. From our health program, I wanted to point out our hepatitis B program. So this is the main topic of the day, right? So FAO has trained many cultural health navigators over the past 10 years. And we have improved also the knowledge about hepatitis B infection among thousands of African and Caribbean immigrants in the greater Philadelphia. We have trained hundreds of African and Caribbean immigrant members in Philadelphia, and we have been able to link those who were impacted to care. Next slide. So hepatitis B screening happens, every year. And we have noticed that since 2023 until last year, we have noticed an increased number of positive cases. So that number ranged from 12 to 18 cases that were positive, and this represents about 12% of those who were screened. So this high number actually shows that not only African and Caribbean immigrants living in the greater Philadelphia are at high risk of hepatitis B infection, but also that there is a need of a HepB vaccine in the community. So next slide. All right. So we know that Pennsylvania, and particularly Philadelphia, is home to many African and Caribbean immigrant population, right? And this population are at risk, and even according to the CDC, it's well known that many African and parts of Caribbean countries have high risk, or they are considered as zones of or areas of endemicity for hepatitis B. So this being well known, so it just entitles that African and Caribbean immigrant communities living in the greater Philadelphia, even in Pennsylvania in general, are at high risk of hepatitis B infection. So what are the barriers now? that are preventing from vaccine. So few barriers that we have noticed since more than 10 years now that we have been working on this program, hepatitis B program, we have noticed that in the community, there's some lack of awareness and knowledge about hepatitis B vaccine, and also about hepatitis B infection in general. This is so important to highlight because we have noticed that many community members do not think that they are at risk of hepatitis B, and they are not aware of the prevalence in our community. That's one thing. There is a cultural and language barrier as well that we need to point out. So in so many African cultures, prevention is not routine, right? Community members do not feel when they do not feel a disease or an illness, it doesn't seem necessary for them to get vaccinated for that illness. So that's one thing. The second thing also is that many of the information or the materials that are available when it comes to hepatitis B vaccine or hepatitis B infection, those materials are not always translated in the language that is appropriate for them. When I say appropriate, it's basically in the former, because some community members might be able to speak the native language but cannot read at some point, or they have low literacy level. So providing some messages that are mostly verbal instead of written will work better for them, but this is not always available. That's one thing. So another barrier that what has been identified is the lack of trust. And this is shaped by the past experiences. So mostly for some families who are living in the greater Philadelphia who have had or they have experienced a painful situation with some vaccines in the past, they will be very scared, and that they are in lack of trust because sometimes in the past, some side effects or some experiences that were not welcomed by the community members who were expressed have not been taken into consideration. Next slide. So other barriers are the limited accessibility due to the hepatitis B vaccine. This is due to cost, to lack of insurance, also some structural barriers, especially when it comes to the healthcare system. Another barrier is the hepatitis B vaccine that is not always available. So most of the programs in the community that provide hepatitis B vaccine to the community members, those programs are usually either they are not funded or they are short-term programs or they are just underfunded. There are some missed opportunities as well during routine clinical visits, like during the checkup visit, for instance. There is not that conversation around hepatitis B vaccine or hepatitis B infection and the importance of preventing hepatitis B infection in the African and Caribbean community. Next slide. So after the barriers that we have identified, we want to highlight a bit more, go deeper in the topic and talk about the parents' concerns, right? So one of the biggest concerns from the families that we have been supporting in the community is the safety of the hepatitis B vaccine. And this safety, again, is shaped, the fear, especially the mothers, the fear that there is no need to provide a vaccine to a newborn, or the newborn has received already so many vaccines. So they fear that too much vaccine might be at some point lethal to the newborn or very dangerous to the newborn. That's one thing. Another concern from the parent that we have identified was the limited understanding of hepatitis B and infection and hepatitis B vaccine. They do not believe that not African and Caribbean immigrants are at high risk, and they feel like it's not the way of transmission. Also, they feel like it's just by sexual transmission, which is not the case. So there is so many myths around that in the community. Another issue is the low perceived risk. As we said earlier, that most of African and Caribbean immigrants in the greater Philadelphia, they do not feel like they are at risk for hepatitis B infection. And again, this is related or linked to the lack of knowledge or awareness around the disease. Next slide. There is also a mistrust. Some parents have shared the mistrust of the healthcare system. They do not trust the healthcare system because of some past experience again that has not been well handled. There is also a misunderstanding of the vaccine information in all the language barriers. Again, all these have already been listed before, but coming from the parents as well, we have heard things like that. There's a cultural belief also in some African cultures. The vaccination is not a thing, like it's discouraged actually to vaccinate community members, especially the children. Next slide. So after all that list of barriers that we identify in the community, the concern of the parents, what are we doing at FAO? So some of our strategies to overcome these barriers are to do some community health education. And we have been doing this through our educational workshop in the community. So FAO also utilizes trusted messengers, especially for our cultural and health navigators. They are seen as community ambassadors. They are seen as trusted messengers in the community, and they are more likely to change behaviors. Also at FAO, we have screening events, and we provide hepatitis B screenings at our health screening events, but also we make the hepatitis B vaccine available to family members. Next slide. So how can providers, particularly doctors, speak with African immigrant communities about hepatitis B infection and hepatitis B vaccine? First, we think it will be great to build trust and respect because, as we have seen or we have heard earlier, the mistrust is a big part of the barriers that we are facing. So build trust is something that is really important, but also to respect, to validate concerns from family members, from parents, from mothers, and to lift up myth, to explain to them. That's one thing. Another thing also is to use clear communication. Sometimes during doctor's visit, the language is not always available. Like the appropriate language is not always available. So the translation at some point is not appropriate, and the families misunderstand some information that they receive from the providers. That's one thing. Sometimes also family or clients cannot actually express in their own language how they feel or what they think about the vaccine or something else. So it's really clear to establish that, to clarify things to community members, to families, and to use appropriate maybe language services to overcome this barrier. Another thing is to address key concerns because for sure, families, especially mothers, have had some concern. There are some concern behind not willing to vaccinate the children, the babies. So it's really important to address those concerns during the doctor's visit. Next slide. Also, we think doctors should encourage dialogue and ask questions. We know that during the checkup visit, for instance, there is a short time that is allocated for that. So the families do not always have time to ask all the questions that they need to be answered. So I think by providing them that time, encouraging the dialogue, let them ask questions, it will help to kind of demystify the hepatitis B vaccine in the community. It's important also for the providers to highlight the importance of the hepatitis B vaccine in prevention and to share resources with the families, with the patients, like where they can find the vaccine, how they can get access to the vaccine, and so on. It's important also for providers to collaborate with trusted community organizations like FAO and some community leaders as well. For instance, at FAO, we have been able to get involved community leaders community faith leaders in the discussion, and that has provided us a very good outcome. Next slide. So, a few takeaways that I wanted to share is that some barriers to hepatitis B are not just individual, right? Especially hepatitis B vaccine. Those barriers are not individual. They are mostly rooted in trust, access, and also system. They are cultural, yes, but the system as well. And without hepatitis B vaccine, there is a high risk for the hepatitis B infection in the community to get worse. So it's really important to prevent this in making available hepatitis B vaccine in the African and Caribbean immigrant community in Philadelphia. Next slide. So I came across this picture and the way it made me feel, I wanted to share with everyone here, like, okay, this smile of this woman, yeah, it shows just the impact of prevention. And making the hepatitis B vaccine accessible means that more children and families will stay healthy in the community. Okay, thank you. Next slide. Next slide. All right, thank you.
Thank you so much for that wonderful presentation. I will, we have a couple of questions in the chat. I know we don't have much time left, but I do think we have some really important questions. So, first, I think the most prominent question that people have, and Sherry has been answering this, but Sherry, could you please just reiterate for the audience what the recommendation is for um, pe parents who are refusing the vaccine or HBsAg if they're positive or unknown? There are a lot of questions about if it's a recommendation just to counsel and document the refusal, or if other things are being suggested for birthing hospitals to do.
Right, right. That's a great question. So our biggest recommendation at the Pennsylvania Department of Health is to get a policy in place to anticipate this. The policy should definitely include education. It should include statistics. And you have to remember the population that has perinatal Hep B. Remember, 90% of them, up to 90% are foreign born. Most don't understand. Most are asymptomatic. So you really want to have a very, very strong education piece. We also recommend speaking to your legal counsel prior in creating this policy. That's also a key aspect. And of course, absolutely documentation, and then the last step is notifying us at the PA Department of Health. If they live in our Pennsylvania, if they live in Philadelphia, you would be notifying Jennifer in the Philadelphia Health Department. So we are sharing these slides. So Michaela will be sending these all out to everybody, and it is all spelled out in there. Education, the legal aspect, and creating policies.
Thank you so much. And then I have one final question for Afisa because I think this is great. It says, in this culture, do you see that the mothers or fathers make the decision about vaccines?
From my point of
Yeah,
view, I'm seeing a combination. It's sometimes one parent feels stronger than the other, so then the other parent kind of leads and the other one just kind of follows. We do see a big combination. I think if I had to pick one parent more than the other, I would say it's more the women making the final decisions, but I definitely see men leading it too, and the women just saying, okay, you know.
Thanks, Lisa.
yeah, yeah. I wanted to add a little bit to that. In the African and Caribbean culture, mostly men are the decision maker, even though the women are behind the scene, impacting or influencing the decision of the man. That's how the family dynamics in general, you know. So when it comes to the hepatitis B vaccine, in yeah, the last decision, I mean, the father will have to make the decision at some point, but might let the woman or the mom kind of voice that decision. But we need to know that it was a decision from the beginning, like, okay, from the father. Sometimes what providers might see, they might see the woman taking a decision, I mean, voicing a decision, but we need to know that behind the scene, there has been some kind of discussion going around, and the father has made the decision, then the mother can voice it. Thank you.
Michaela, if I can answer that one question that just popped up for Carolyn. It
Sure.
just says, so just to clarify, the position of the Department of Health would not be to recommend going to court. No, that is not our position. We are recommending you talk to your legal counsel. That is what we foremost recommend. Please talk to your legal counsel and decide from there.
Wonderful. Well, I just want to say thank you, everybody, for staying on a few minutes late. As I mentioned at the beginning, this has been a webinar in partnership with the Pennsylvania Department of Health, and we are so happy that we had this really robust conversation with you all. Thank you so much, Lauren and Sherry and Nafisa, for joining us today. We will be sending the slides and the recording around, so you will have access to all of the resources mentioned today. You have my email if there are any other questions that pop up. But thank you all for joining and for staying a little bit later, and I hope you have a great, fantastic rest of your week. Bye.
Bye. Thank you.
Thank you, everyone.